All right, it looks, I got a message that says we are being live streamed. Did others see that? Okay.
Yes, we should all be live, Audrey.
Yes.
Thank you,
Okay.
Elliot and
Thank you.
Kirsten.
Well, welcome back, everyone, to our regularly scheduled programming. Do we need to redo the roll call for the record? For the
I
public
believe
record?
so.
I think that's
Okay,
right.
Kathy, take it away.
Okay. Good morning, everyone.
Good morning.
Good morning.
Rebecca,
Present.
Michael,
Present.
Elaine,
Present.
Eric,
Present.
Matt. Oh, I'm sorry,
Present.
Martha. I'm reading Martha.
No worries. Barth Kwasnik for Secretary Gorkowitz.
Okay. Keisha is not in attendance. Dimitri,
Here.
Secretary Walsh,
Here.
Nancy,
I'm here.
Matt,
I'm here.
and Rena. Rena.
Sorry, I'm here. I was on mute.
Okay. All right. Thank you, everyone.
Oh, good morning. So I have a very important first order of business today, which I'm delighted to do at my first meeting, which is to let this board know that Audrey Morse-Gasteyer has been named the Executive Director of the Massachusetts Health Connector. Congratulations, Audrey. Long overdue, permanent, no interim, just in time for a major redetermination effort. So welcome aboard.
Thank you so much.
So that's the first item on the agenda, and let the minutes show that the board is very excited about this appointment. I believe and happy to have Audrey in this role, confirming the role she's taken, leading us through this next phase of important work for the connector. The next item is the approval of the minutes of the February 9th meeting. And I need a motion.
So moved.
Thank you.
Second.
Thanks, Nancy. Then I think we need to record the vote individually again.
Yes, we do.
I'm reading my notes right? Okay. Kathy, I'm going to leave. Please just make sure I don't break any laws.
Okay.
Open meeting laws. Thanks.
All right. Rebecca.
Abstain. I was not present. Thank you.
Okay. Michael,
Yes.
Elaine,
Yes.
Eric,
Yes.
Martha.
I think I need to abstain because I'm a new designee. But I'll leave it there.
And you weren't at the meeting, so that might be wise. Were you at the
I
February
was
meeting?
at the, sorry. I was at the meeting, but as the DOI designee. But now I'm for ANF, so I think I need to abstain. But I can talk offline about it later. But we'll record as abstain for right now.
Okay. Dimitri,
Abstain.
Secretary Walsh,
I'll abstain as well.
Nancy,
Yes.
Matt,
Yes.
Rena.
Yes.
Thanks, everyone.
Great. Okay, well, I'm off to a great start here, but now we're back. I want to record the vote as having carried, and the motion carries. And we'll move on to our first item, which is our new executive director's report. Audrey.
Wonderful. Thank you so much. Good morning. It is great to be back with you all today. Before we dive into our agenda and my remarks this morning, I did just want to extend a heartfelt welcome to our new board chair, Secretary Walsh. Secretary, we are thrilled to have you leading this board and the Executive Office of Health and Human Services. We look forward to working so closely with you and your team and the Healy Driscoll administration to advance the Connector's mission and the Commonwealth's goals around healthcare and coverage more broadly. We feel truly grateful to have you here and your depth of expertise and experience at the helm. And I also want to thank you for appointing me Executive Director of the Health Connector. I am deeply grateful for your confidence and support and for the support of this board, which I have loved working with over the years. I'm excited to get to continue to work arm in arm with each of you and the extraordinary team at the Health Connector in pursuit of our mission. It's an honor to be given the opportunity to lead an organization that continues to work tirelessly to build, strengthen, and improve the health coverage we provide to the Massachusetts public and serve the public interest. I view it as a privilege to get to do this work, which affects the health and financial well-being of so many residents in this state that I love. And I could not imagine a better board chair, and colleagues at the Connector with whom I get to move forward into the future and chart new ground together. So thank you all sincerely. As we turn to our agenda for today, I want to reiterate for the board that the Connector's topmost priority continues to be our careful preparation for the MassHealth redetermination process that will first start in April. We are squarely focused on ensuring that we successfully and smoothly enroll as many as possible of the hundreds of thousands of residents who will newly need health coverage over the course of the next year. As we prepare for the redeterminations from MassHealth to start after April 1st, we have a number of updates and new initiatives to bring to you since we met with you last month on this topic. Today, we'll be asking for your vote on an outreach and visibility campaign to engage and educate the residents that we need to ensure successfully transition from MassHealth to the Health Connector. It will be our most ambitious public messaging effort since we launched the new HICS in the fall of 2014. We know that the residents who are expected to lose MassHealth coverage over the course of the next year when redeterminations are conducted are in the hundreds of thousands, and our goal is to ensure that all of these people have new health coverage when they need it. Our public campaign will ensure the connector is visible to everyone in the Commonwealth as we go through this process, and that the public understands the connector is here, ready to enroll them, and we are the only place you can get state and federal help paying for coverage, and that our coverage includes key benefits and consumer protections in line with state and ACA standards for coverage. On that point, as we head into this market transition, we do continue to be on high alert about scam health plans, healthcare sharing arrangements, and others peddling non-ACA compliant coverage online in particular. As this board has discussed in past meetings, we know these entities market what appears to be affordable coverage, but leaves residents with unpaid medical claims and none of the consumer protections people have come to expect and deserve from real coverage. So one of our goals this year is to make sure Massachusetts residents avoid these traps and land in legitimate coverage that will be there for them when they need it. So dialing up the volume of our outreach voice and community presence to attend this year and beyond will be critical to drowning out pitches from these kinds of entities. As you'll hear from the team today, our community-based activities will include a new mobile community specialist program with 4 regional teams out across the Commonwealth, rotating to different locations on a regular schedule to provide flexible in-person redetermination and enrollment assistance. We continue to hire and train representatives for our customer service center, working with our call center vendor to ensure residents who call in have the support they need to get into the right coverage plan for them. We continue to work really closely with MassHealth and others on outreach and education, including participating jointly in briefings with a variety of stakeholders, advocates, community leaders, and others as we prepare for the process to start next month. While we at the Connector expect to enroll a significant share of the hundreds of thousands of folks losing MassHealth, we know that for many people, their employer's plan may be the right place for them to land. To support those transitions, we're preparing a collection of materials, including FAQs, template newsletter copy, flyers for employees, and other resources for the employer and broker community, ensuring that they're aware that their employees may need coverage through employer-sponsored plans as they move off of MassHealth. All told, we remain committed to envisioning and preparing for every aspect of this transition event and leveraging every tool we have to make sure Massachusetts holds the line on health coverage. But stepping back from the immediacy of the redetermination effort, our mission is not just to connect people to insurance coverage and consider the job done, but to help empower members to use the benefits and services enabled by coverage to live healthier lives. Today, Sam will walk you through a preview of our seal of approval for 2024. As always, this includes nuts and bolts updates to product designs based on adjustments to the federal actuarial value calculator and other routine refinements. But beyond those core product design adjustments, the seal of approval process also provides the Health Connector the unique opportunity to leverage its partnerships with carriers through the seal of approval RFR and contracts to advance key policy and market priorities in ways that encourage common market-wide action and focus on key policy objectives. For example, you'll recall last year we used the seal of approval to introduce a number of equity-focused goals, like announcing we would require all on-marketplace carriers to participate in the Connector Care program, introducing equity-focused elimination of cost sharing for drugs and services to manage key chronic conditions, and requiring policies that would promote behavioral health and ensure carriers were engaging with the transgender community around their healthcare needs. This year, we've identified another key health equity topic to apply seal of approval leverage to, and that's the overwhelming evidence that many of our residents, including insured residents and Health Connector members, are underutilizing key healthcare services, including preventive care, which are available to them at $0 thanks to the ACA. And state data shows us that it's often people of color, people with lower incomes and lower education levels whose utilization of preventive services like cancer screenings lag behind. For example, we know from DPH data that Black non-Hispanic men have higher cancer rates than the rest of the state's population, but for many cancers, their screening rates lag behind other groups and they are diagnosed later than other groups. This is a life or death inequity in the health coverage landscape that especially the marketplace, like a marketplace like the Health Connector, which covers a diverse public, can and should look to find ways to reverse. Massachusetts works so hard to promote coverage to all residents, but we can't accept the fact that among those covered residents, there are populations getting less life-saving preventive care out of that benefit. As you'll hear from Sam, our forthcoming 2024 Seal of Approval RFR will require carriers to partner with the Health Connector next year on a joint multilingual and multimodal outreach campaign, focusing on promotion of preventive services to our members. This includes primary care office visits, preventive screenings for colon, breast, and cervical cancer, and will require carriers to adopt home-based testing for colon cancer screening. We look forward to working with our carrier partners and others on bringing this area to the forefront and using the Health Connector Seal of Approval as a tool to further close the health equity gap in the Commonwealth. We look forward to using data to measure the impact of these kinds of efforts that we're using the Seal of Approval to push forward so that we can learn, iterate, and adapt together to ensure our actions are making a difference. So between preparations for the Medicaid redetermination process and our ambitious plans for the 2024 plan year, leveraging our Seal of Approval tools, we have a lot to be excited about and talk about today. And thank you, as always, for your support and insight as we continue to make the Health Connector stronger than ever for more people than ever.
Audrey, any questions for Audrey before we move on to the meat of the presentation?
Just a quick comment, if I may, Madam Chair. This is Matt from the GIC. I just want to acknowledge, Audrey, the work you and the team are doing here, leading on health equity. Just as a purchaser, you and I have certainly talked about these issues and how the GIC can align with some of the work that you're doing here for our members. So I just want to thank you for the thoughtfulness that you're bringing to this and the creativity. We've raised some of these issues with some of our colleagues in other state, our peers in other states, and I was actually sharing some of our thinking based on some of your thinking, and it really is, I think, kind of leading the way, not just here, but elsewhere. So just want to acknowledge that. It's really impressive. Thank you.
Thank you, Matt. I really appreciate that.
Can I just add to Matt's comment, which I think is very well deserved, that particularly over the next few months, one of the most successful health equity interventions the state has ever done is expanding coverage. And we know that the expansions from Chapter 58 and subsequent did more to reduce racial and ethnic disparities in this particular area, which we know is necessary but not sufficient. So I just also want to say the work that we're going to be doing over the next year to keep everyone in coverage is also a health equity initiative as well.
Absolutely. Thank you for that, Nancy. Couldn't agree more.
The only thing I would add is Audrey and I had exchanged before this meeting when I read the materials, and I think it's really important that equity is part of our Seal of Approval process. I think that's to copy Matt's language. I think that's necessary but not sufficient. I think the next phase of this work will be sort of a deeper dive on how our plans perform, the outcomes we're seeing, not just what we're saying. And I think that that journey can be a little painful and takes a while and requires all of us to think, a little bit more creatively about what it is we can do with these products to kind of stretch the definition of equity so that as many people in the Commonwealth who we are, lucky enough to insure and provide insurance for, actually live the lives they're meant to live. And I think that journey is one I think that Connector is really well positioned to go on. But to Nancy's point, you're going to be picking up a lot of people who've been in a very different coverage system, and they're going to have to learn how to how to work within a new set of rules and constructs. And even modest copays or premium supported plans are different than MassHealth was for them. So we need to help people on that journey. And that I'm very excited about even in, I think I'm on day 8 or something, the amount of work I've seen. Audrey and I had an opportunity to brief the governor and lieutenant governor on this redetermination process. And, you know, it won't be perfect, but it won't be for lack of trying.
Thank you, Secretary.
I'd like to add one more thought, just representing the brokers and employers in the state, that whatever we do here can be a springboard to the rest of the market. So we don't have to look at just what the connector is serving, but as we develop standards and best practices through the connector's work, we then in the private industry look at that and say, okay, look what we're doing over here, carrier X, Y, and Z. We need to take that and apply it to the rest of the market. So it really is setting a wonderful precedent if we could do the hard work here and then expand it beyond just the connector's clientele.
Great. Thank you, Eric. I think I'm supposed to move us along now and introduce Samuel, who will kick off a presentation on the 2024 preliminary health and dental plan seal of approval.
Yes, thank you.
Steve.
Good morning.
Oh, there you are. Okay, hi.
Here.
Morning.
I'm prepared to share my screen, so that should come up any moment. Are you able to see the screen now? Yes. Okay, great. And good morning again. The proposals you'll hear today usher in the 2024 seal of approval process. The seal of approval seeks to obtain proposals from health and dental issuers to offer plans for sale through the Health Connector for coverage effective January 1st, 2024, and available to consumers at the commencement of open enrollment on November 1st, 2023. This process relies on close collaboration between the Health Connector and the Division of Insurance to ensure that all plans certified as qualified health plans and qualified dental plans meet necessary state and federal requirements. This presentation today is the first of 3 seal of approval presentations in the calendar year. In March, staff present a strategic proposal in advance of the issuance of a request for responses. In July, staff present the proposals received from health and dental issuers and seek the board's input and vote on the conditional seal of approval. And in September, the final proposals, inclusive of final rate filings, are proposed for the board's consideration and vote. Health Connector staff recommend a stable product shelf for 2024 with key goals to advance existing health equity initiatives, strengthen the marketplace and connector care program, and address population health objectives. In 2023, the Health Connector brought forth a significant set of changes highlighted by setting cost sharing at $0 in the connector care program for drugs in treatment of diabetes, hypertension, asthma, and coronary artery disease, chronic conditions disproportionately affecting people of color. Other changes included coverage recommendations of new mental health provider types, expanded PPO availability in the small group platform, the addition of federal quality rating system display, 2 carrier rebrandings, and transition of membership from plan closures. The 2024 seal of approval emphasizes a stable product shelf that includes improvements to coverage in support of smooth member transitions following the redetermination of MassHealth membership. And the seal of approval also presents enhancements to the connector care program and advancements of population health initiatives. To help inform policy development, the Health Connector issued a request for information in December of 2022 to seek feedback on coverage priorities. Key areas of focus were behavioral health services, preventive care, and pediatric mental health services. Staff also sought feedback on plan and product design improvements, including feedback on value-based insurance design initiatives and availability of plan information through online resources. We also inquired about policy development and programmatic tools to help moderate overall healthcare cost growth and requested information about risks of inequities in clinical and population health data analysis. 12 organizations, inclusive of health and dental issuers and insurers, state agencies, and community partners submitted responses, and staff can provide copies or summaries of any areas of interest. We've outlined the major themes and focus areas of the seal of approval on this slide, and I'll walk through the 5 key areas up front and proceed with further detail in the subsequent sections. Beginning with the product shelf, we proposed updates to standard plan designs to account for technical changes in the 2024 Federal Actuarial Value Calculator, And these proposals reflect the Health Connector's focus on improvement on first dollar affordability in standard plan designs. We propose incorporating areas of coverage in support of state-based equity initiatives to provide greater value in health plans, including alignment with shared recommendations on maternal health, behavioral health, and pediatric mental health efforts. Staff also propose to require all carriers to participate in a joint outreach campaign with the Health Connector, as referenced in opening remarks, during the 2024 plan year, in order to encourage primary care visits and preventive screenings for colon, breast, and cervical cancer, as well as routine cleanings for oral health. The Health Connector views this outreach as an opportunity to address higher incidences of foregone and deferred care, especially among insured individuals, and to collaborate with carriers and other stakeholders on strategies to measure this approach. We also share some national and Massachusetts specific research from agency partners. In parallel here, we propose to incorporate and itemize into the RFR procurement the ACA preventive service requirements that are currently being challenged in federal court in order to safeguard these $0 protections for enrolled members going forward. Through the RFR, staff proposed to issue clear and impartial guidance on programmatic, technical, and business rules to introduce updated guidance for the Connector Care program expansion. And lastly, program stability is our underlying driver in our work in 2024, which will allow us to carry forward VBID and existing value-based insurance design or VBID initiatives, maintain a stable suite of product offerings for membership in all program types, and preserve the programmatic goals of increased access to affordable health care for those with the greatest need through Connector Care coverage. Yes, Michael, I see a question.
So as you might imagine, I think all of this VBID stuff is wonderful. I have a quick question and a quick comment. The quick question is, it has been a challenge to do this type of thing on the exchanges because the actuarial value calculator, you have to find other places to offset. So I'm interested in your thinking about that and how much of this is coming through sort of what I will call wiggle room in the calculator, as opposed to other trade-offs in the seal of approval and what those trade-offs are. My second comment is, I'm really supportive, and actually with a colleague of mine at Michigan doing a lot of work on some of the cancer screening stuff that you have listed in the second bullet point of the third row. The concern that we've been having is, it's great to have the lower cost sharing for the screening, but sometimes you end up with a lot of people that have gotten screened with potentially uncertain or concerning results, and then they have to pay a lot for the follow-up. So trying to think through this in a sort of patient-centric way is important, because having really high cost sharing for your, say, follow-up biopsy or whatever you need ends up just making the screening super frustrating for folks and prevents people from getting the care that they need. So thinking about how to do that sort of in a care pathway approach as opposed to a prevention versus not approach, I think is important, but we're, I think, constrained by the AV calculator. So anyway, those are my comments.
No, thank you, and noted. So those are the diagnostic screenings that you've seen that are causing some pricing issues.
If I can just pick up a little bit on Michael's point, that was the point I was trying to make about sort of deepening our understanding about what equity means behind the seal of approval, what steps would plans and consumers have to take to make that compact really work. And so I think it gets into sort of the guts of it in a way that we're, that's what this is the beginning of our journey.
Sure. I did want to note, Michael, your comments on the AV calculator. In this next section, I do address that a little bit, so we can, I'll just move forward, and I think I should be able to answer some questions on this slide. So in this section, we provide some details about the proposed changes to standard plan designs. The Health Connector's standard plan designs each contain 22 standard benefits with prescribed cost sharing within the bounds of guidance in the federal AV calculator. Our philosophy has been to encourage copay first services where possible, as opposed to alternatives like co-insurance and tiered cost sharing. So there's a key change this year to the AV calculator right now that's updated the underlying logic so that copays not subject to deductible no longer accrue to deductible. This correction allowed for proposed plan design on the silver tier with more generous member cost sharing and more room in the AV. So this allowed us to lower copays on cost sharing for PCP visits and tier 1 medications. We've also proposed to increase the maximum out-of-pocket amount on this plan as with previous SOA cycles. On standard high gold and high bronze designs, the maximum out-of-pocket amounts were also increased in order to avoid increases to cost sharing on these plan designs while fitting in the AV parameters. So we found some more room on the silver design, but we still see pressure on both gold and bronze to stay, within the existing design parameters of cost sharing, copay first. And we do have the designs in the appendix too, if there's any follow-up questions.
And Sam,
Michael, what's the fix for this? I mean, what if they asked you what to do, what would you recommend?
So the short answer is coverage for the follow-up care.
Yeah.
The problem with why that's not an answer has to do with how it fits into the AV calculator. And we had for those that are new, we had a whole work group with a woman who's outstanding named Emily Bice, who used to be at the connector, to try and figure out how, and John Burtko, who actually takes the blame for the actuarial calculator, who's covered California for a while. Anyway, about how to solve this, it turned out to be much more challenging. So the question is, there's just trade-offs that you have to make in how you do the seal of approval to make sure that this happens. And that isn't being very detailed, and you inevitably, because of the actuarial value calculator, except for when you get, don't take this the wrong way, free money because of the technical changes, you end up having winners and losers. And that ends up making the seal of approval type discussions much more complicated, because you can't do things that obviously should be done, like making sure women that have an abnormal mammogram get a biopsy without some exorbitant cost or whatever follows up that. That turns out to have to happen with some trade-off that whoever's on the wrong side of the trade-off doesn't like, and that's very complicated. So the reason I'm rambling, Nancy, is because I don't have an answer. So maybe I'll just stop rambling.
Yeah, it wasn't rambling. It just sounds like it's
actually, I will
solve.
say one other thing, Nancy. Back when I had less gray hair, I was working with the Department of Community Health in Michigan to try and get insured disadvantaged women access to breast and cervical cancer screening, and they had CDC funding to get the prevention done. They had no funding for the follow-up care. And what they did, which is not really a great equilibrium solution, is they just begged providers to do it for free.
I would just also add, Michael, to your question, we have more flexibility than most any other state-based marketplace, at least as it relates to the connector care program, because we are not confined by the bounds of the actuarial value ranges, because we use state funding to fill in what we think is important from a program or policy perspective. And that's how we did those VBID adjustments last year around the chronic condition copays. So I think your point is really well taken about the follow-up care and cost there, and that could be an area for policy discussion to think about in the connector care space, because we do have more flexibility there. It doesn't solve the problem for people outside of the reach of connector care, but we do have that additional flexibility from a program perspective, just to note.
And it's analyzable, because it's an enormous hit to the individual consumer. It's probably relatively short dollars in the total connector budget. So I think there may be an opportunity here. That's what I mean about getting under, I keep repeating myself, but that's like really getting under the hood of equity. That's exactly the kinds of things you have to start to look at. And there's products and your own product design in a way that advances its goals, not just kind of asking carriers to do things. Yeah, it's actually how we design, really just follow the money.
Yeah.
We shouldn't dwell on this too much, but just so you know, yesterday, the VBID Center at the University of Michigan had an equity-focused conference for 4 hours on how to promote equity writ large. One of the speakers was from the DC Exchange. that is really outstanding. There's a bunch of exchanges, DC being one. Us, by the way, we were also mentioned, just to be clear, that emphasize the type of things they're doing in this space. And for the exchanges that really care, I do think Colorado, California, there's a subset of people trying to come up with this broader. And I know you guys have been involved in that.
Yeah, absolutely. Thank you, Michael.
I just had a couple other points on product shelf and plan design before moving forward. So at this time, we do not recommend any changes to the structure of the small group shelf in order to fully evaluate the full enrollment cycle experience for employees and employers in acknowledgement of expanded availability of PPO products we made in the last plan year. And we look forward to continue to extend our existing VBID initiatives related to $0 chronic conditions, $0 insulin and medication and delivery, and $0 medically assisted treatment cost sharing in the Connector Care program. On the next two slides, we describe some areas of health equity and value separate from product designs that the Health Connector seeks to prioritize in the 2024 seal of approval. Areas of focus here include protecting access to preventive care services in alignment with state efforts to enhance maternal health coverage, while seeking to improve access to behavioral health providers, including community behavioral health centers, and finally, to encourage access and information about pediatric health and dental services. In the preventive care space, we plan to leverage an existing process in collaboration with federal reporting templates and request for carriers to submit a new quality improvement strategy to incentivize primary and preventive care utilization. We also propose to add requirements into the RFR to guarantee continuance of protected preventive care services in Health Connector QHPs in response to the pending legal challenges to the ACA's preventive service mandate. And finally, staff proposed to encourage parity and reimbursement for telehealth services that are audio-visual and audio only and consistent with existing regulatory requirements for in-person parity. On maternal health care, staff continue to work with MassHealth to promote access to doula services for members and expects issuers to follow developments related to licensing and accreditation in preparation for coverage in upcoming plan years. Yes, Nancy?
Sam, what do we know about like workforce capacity in the doula area? Maybe a little hard since there's not licensing and accreditation now, but are there plenty of doulas once they're covered, or is there a shortage? Or
yeah, I haven't been as close to the amount of providers, but I think with licensing and accreditation, that's the first step and to evaluate the size of the workforce. I can imagine,
there's more demand for doulas than there are doulas based on
exactly.
yes. BMT experience, and I think that's going to continue. It is, again, it's an incredible program. It's also a real equity boost because it's a pathway for the doula to get into other jobs and roles. So it's I think there's real opportunity, and we should probably maybe work with MassHealth, which is also obviously to create training programs. Probably is too strong a term, but sort of kind of an approach or background that people should have, or just some basic training that people need. Right now, hospitals and and CHCs are doing this on an ad hoc basis, but maybe we could formalize something. That would be a good mini project for somebody.
Yeah.
We'll take that on.
Okay.
It's a great question and a great topic and a really important field we want to see grow and hopefully
Sam, as I demonstrated at the outset of the meeting, time management is not a skill set. So you've got about 10 more slides and about 10 more minutes.
Okay, I'll do my best.
We can go a little bit over, but I think,
sure.
Yeah.
Some other initiatives where we'll cover, we propose to collect information from carriers and in-network availability of essential community providers, such as federally qualified health centers, family planning providers, and community behavioral health centers in order to improve data available in provider search. And staff also recommend using the RFR to provide alignment with regulatory guidance about pediatric mental health coverage support and services available. And just moving ahead here, the Health Connector serves a large and diverse membership through the Connector Care program with intent to provide accessible, stable, and affordable health insurance coverage. Through the 2024 seal of approval, the Health Connector looks to focus on the opportunity to close the gap on preventive service utilization and reduce incidences of foregone care by working to ensure that the free life-saving protections of cancer screenings and preventive care are equitably utilized by the full range of members. We view foregone preventive care among enrollees as a key health equity and population health challenge in the Massachusetts healthcare coverage landscape that the SOA contracts can be leveraged to address. Despite Massachusetts' nationwide leading rate of health coverage, we've seen extensive evidence suggesting that even among insured residents, lower income and people of color are utilizing fewer healthcare services generally and are more likely to forego cancer screenings that are guaranteed at $0 cost sharing upfront. A specialized effort is needed to both further understand barriers preventing insured individuals from benefiting from these coverage guarantees and to collaborate on efforts to address barriers to care and facilitate utilization. Seal of approval contracts will newly require collaboration between the Health Connector and carriers on these efforts. We've seen some research and evidence at both national and state levels highlighting disparities in cancer screenings and cancer incidence. For example, despite higher colorectal screening rates in Massachusetts overall than in other states, screening rates were lower and closer to the national average for Black, non-Hispanic, and Hispanic groups in Massachusetts. We've also begun to understand the compounding effects of lower healthcare utilization and screening disparities amongst communities with lower income and education levels. For example, colorectal screenings among all adults with less than $25,000 household income and those with less than high school education were less likely to be screened than their peers with college or more education and household incomes greater than $50,000. Research by the Health Policy Commission and as articulated in the Attorney General's 2022 Cost Trends Report have found that close to 16% of insured individuals in the lowest incomes in Massachusetts had no medical spending in 2018, as compared to close to 9% of insured individuals in the higher income communities. Taking steps to address these concerns, the Health Connector recommends a multilingual and multimodal outreach campaign in joint collaboration with health and dental carriers, focus on PCP visits, preventive care screenings for colon, breast, and cervical cancer, and routine dental cleanings. Furthermore, staff propose to require health issuers to adopt coverage of home-based testing for colon screenings in line with recommendations from the U.S. Preventive Service Task Force. And we also recommend implementing new reporting requirements to capture and measure utilization of services using both programmatic data, such as program type, plan type, and metallic tier, and demographic data such as race, language, and ethnicity where possible and where available. We welcome feedback and strategies to evaluate and impact and measure outcomes of both new initiatives and some of our existing initiatives.
Sam, can I just
Yes.
interrupt you or back up on the SOGI data?
Sure.
People are going to be collecting this for MassHealth for the waiver on this patient population. So maybe there's a way to make sure, you said where available and as available. Maybe there's a way to strengthen our processes so that it transfers with the patient. I don't know if there are privacy concerns, but I know MassHealth is going to be collecting it as part of the 1115 waiver, and it's the equity initiatives that are embedded in that. So we might want to just strengthen that language a little bit. Sorry, I didn't catch that in the pre-read. And I see Dimitri has a question.
Thank you, Commissioner. My question to Sam with regard to the data collection that you're looking at. I was curious as to how we can leverage data certification in the area of equity as it relates to some of the payers, specifically as they participate or have stood up there on ACOs. They are looking at data certification from the quality perspective. How do we leverage that same information so we can educate our consumer?
Sure. I can start. We have a few initiatives in progress to improve data collection and be able to share, through our application process and improve the quality of data. I think there's some, and I'd welcome comments from colleagues a little closer, but I think there's some areas of response that don't always get the best kind of quality of data in the collection. I think we have maybe 70% or so of data that's clear, and there's some areas where we've been working to improve the collection capability.
I'm sorry. Are we able to stratify the data with regard as we look at the issue of equity so that we can have a better understanding from the payer perspective in terms of whether or not there are patterns that we can identify that we can work with the payer to help address?
Yeah, one area we're pursuing is to link enrollment data and claims data using the all-payer claims database to have a better measurement and combine those two data sources.
All right, thank you.
And Sam, I'm happy to just jump in on the data collection front, just to let everyone know. We will benefit from the same sexual orientation and gender identity enhancements that MassHealth is planning. We've been working very closely with them since we do share our eligibility applications, so we'll have access to that. And we're working with the carriers to make sure that we can transmit it to them so they can use it. The race and ethnicity data, those are optional questions, of course, in our application. So we do have incomplete data, but we're working on ways to help let people know why we collect it, and hopefully they'll see that and want to participate in our equity efforts and provide us with that information so we can pass it downstream to the carriers, and they can then use that in conjunction with what they're seeing on the claim side to identify those kinds of disparities and do that stratification that you're talking about, Dimitri. So definitely an area of focus for us, and we're expecting additional enhancements to our non-group application on this front in July.
Thank you.
I know there's a few comments. I think I saw Philane, and then we can go to Nancy and Matt.
Thank you, Sam. As I've been kind of digesting this information and thinking about how important it is that there's strength and focus on the foregone services, I can't help but also remember that part of the frustration is not the lack of trying. It has to do sometimes with the staffing and the longer wait times to even see a primary care physician, or the lack of diagnostic imaging staff. So I mean, from clinical to non-clinical, I mean, altogether, I mean, I think staffing does become a piece of the puzzle that may not necessarily be here, but is part of the thinking, because I mean, it takes the whole team to try to walk through and keep folks alive as well. I just wanted to share that.
Thank you, Philane. Absolutely agree.
I think Nancy had her hand up before I did. If she had a comment.
Actually, I know we're having time. I had a question about dental, but I'll ask it offline.
So I'll be very brief. So for what it's worth, the GIC, of course, we're also very interested in doing the same kind of stratification on all of the data elements that you mentioned here: race, ethnicity, language, gender identity. And it's a challenge. As Melissa mentioned, it's voluntarily provided information on behalf of our enrollees. We've worked with our carriers to impute that data, and carriers, there's a range of capabilities and expertise there among the carriers, but I think they're doing a better job of that. I see that as kind of short-term filling the gap type of efforts. I'm encouraged by the work that's been led by EOHHS in the past, that I think is likely to continue. We've participated in those working groups to establish consistent data standards that all payers can use. and we're struggling sometimes to sort of figure out what more we can do while those data standards are developed. One of the things that we did that through our recent procurement was to push our carriers to get NCQA health equity accreditation, which includes a variety of data gathering requirements, among many other things. So one of the things to contemplate, I think, going forward, Audrey, as you work with carriers.
Absolutely. Appreciate that, Matt. Thank you so much. That context is really helpful.
I just have one final section to touch upon, and around connector care. We're at the Health Connector, we're continuing to work with carriers on the requirement for all health carrier participation on exchange, and for all health carriers participating on exchange to also participate in connector care program effective in 2024. Historically, we've had a subset of issuers in the program, and over the course of several years, staff have assessed the impact of continuing to allow partial carrier expansion, allow partial carrier participation in connector care. We've concluded that the existing approach, which was a holdover design from pre-ACA Massachusetts market constructs, no longer serves the best interests of the marketplace and Health Connector members. There's, our key areas of focus with this expansion are to improve equity, geographic coverage, and network access and continuity of care. The expansion also protects the program against bare counties, especially in at-risk areas with only 2 existing carriers. And it allows for many members in need of subsidized coverage to have an easier transition from off-exchange to on-exchange coverage. Staff are engaged with 3 new connector care participants to implement the business, programmatic, and technical guidance provided by the Health Connector. The Health Connector is jointly working with the Division of Insurance on guidance to ensure a competitive and fair environment for carriers to compete, with goal in mind to improve member options and access to providers. We also intend to continue the stepwise approach to premium stabilization to preserve member choice and protect against annual premium volatility, while also providing financial support to connector care carriers through an existing process of offsetting the loss of federal cost sharing reductions. And welcome any other comments here or questions. Our next steps are the proposed SOA timeline for the rest of this calendar year.
Myself on mute. Thank you, Sam. That was great. It was a great discussion. If there's no further questions, though, I am going to move us on because the next item requires a vote. It's a presentation on an update of the connector's ongoing preparation for redeterminations. And Marissa is going to kick us. I'm sorry, I'm reading this wrong. It's going to be presented by Patrick Grant, Jason Lefferts, and Marissa Woltman. And Marissa will lead us off, I believe.
Great. Good morning, everyone. So today we'll share our updates on our preparations for members who will qualify for Health Connector plans as a result of the upcoming Medicaid redetermination process. And we'll focus on updates since we briefed you last month, including ongoing contact center preparations, development of mobile outreach teams, and business community outreach. And we'll also request a vote authorizing spending on enhanced outreach and public education activities. As you know, MassHealth is ramping up to begin redeterminations of its members beginning April 1st and continuing for 12 months. Members have not lost MassHealth coverage since March 2020 as the result of COVID-related protections passed on a federal level. While those protections end on March 31st, individuals will have an opportunity to have their continued eligibility for MassHealth considered by completing an annual renewal prior to losing coverage. The Health Connector is deeply committed to making sure that this process does not result in net coverage losses for the state. We've been a national leader in insurance coverage for many years and want to maintain the gains in coverage that we've seen in the last 3 years in particular. While it's difficult to predict exactly where individuals will land as a result of this unprecedented process, we're expecting 100 to 200,000 individuals to sign up for Connector coverage as a result. And on the right here is the framework that we've been using to organize our work with 3 main buckets. One relates to the huge communications and outreach effort to make sure people know where to go to find coverage. The second bucket is making sure we're ready to handle increased volume in all our operational processes. And the third is making the transition process as easy as possible for individuals. So with that, we'll hand it over to Trish to talk about contact center.
Good morning. So we have several waves of onboarding and training that are in process between now and July based on the forecast that we have for staffing. Our first wave of about 80 FTEs began this past week. They were onboarded at the end of February and started their training classes last week. We're actively recruiting for the next wave of approximately 160 FTEs. They will be starting towards the end of March, I believe on the 20th. And overall, we estimate about 400 FTEs to be hired and trained between now and July. We're also scaling up our tier 2 staff, our document processing staff, escalation, and quality assurance staff. Those classes are underway and we expect them to be done by approximately June of this year. We are also cross-training our walk-in center staff and our current paper processing staff. In case we need an all hands on deck for phones, they'll be able to be pulled to help out with phone work. And then we do have a second vendor. We're pending a finalized contract with them. They will step in and help with our paper processing in the event that we call the Accenture staff over to answer calls. And that vendor will have about 30 to 60 individuals. We'll be cross-training them not only on the paper processing, but on outbound calls as well. That way, if we don't need to pull them for the processing, we can have them start reaching out to folks and letting them know the importance of answering the mail that they're getting, the green envelope from MassHealth, to make sure that they're doing their redeterminations.
Trish, can you remind us where these 400 people are going to be physically based, other than the ones who are in the and are they going to work in a sort of virtual call?
Yep, all the
center?
contact center staff is remote right now.
Yep.
And so anybody new coming in is also remote.
But are they all across the country?
Yep.
Like where are they?
Yep, they're wherever Accenture has staff available. They're either recruiting new staff through their temp agencies, or if they have staff who have been on a different project that are ending that project and need a new project to work on, they pull them over into the Massachusetts project. Dimitri, you have a hand up? No, that might be from before.
In prior meetings and in prior year, we wanted to make sure that there was a concerted effort to employ folks from Massachusetts for that work. Have there been any deviation from that, or are we still on target to try to encourage Accenture and all of our other partners to hire folks from Massachusetts first?
Yeah, so the leadership that we work with, some of them are based in Massachusetts. I can find out what percentage of staff we have that are based in Massachusetts. I don't know the numbers, but I can definitely find out for you and get back to you and let you know.
Thank you. And what's the total number of FTEs and what percentage are we hiring for this run?
So it's a little difficult to explain. So each month, based on the forecast and the calls that we think we're getting, based on previous call volume in previous years, both during COVID and before COVID, as well as the schedule of notices that are going out, we look at the length of the handle time. We also look at the contact rate. So each month, depending on all of those different things, the number of FTEs that we need seated and taking calls is different. So there are some months where we think we need over 200, and there are other months where we need closer to 400. It depends on the mailing schedule. As you're probably aware, in August, we send out all of the mixed household applications. And so we would need in September, October, November, likely more staff than we do now. So it could be anywhere from, I would say, in the low 200s to close to 400.
And the reason for my question is I just want to make sure that we don't lose focus on the quality of service to our constituent and the work that has been in the past to improve that service. I want to make sure that we don't lose sight of that.
Correct. In the next slide, I will go over some of the background work that we've been doing. It's great for us to be able to pick up the phones, but we can't just pick up the phone. We need to be able to help folks when they call. So we're working on all of the information that the agents have, the training, their knowledge center information, working with MassHealth to set up escalation processes, so that we're able to help folks correctly and consistently when they call and not just be a body to pick up the phone.
Thank you.
Yep. So on the next slide.
Trish, I think Fellaine has her
Elaine
hand
has
up.
a question.
Oh, I'm sorry.
Yes, I was
I
just
can't
gonna-
see everybody. I'm sorry.
Thank you. No worries, no worries. Trish, I'm curious whether, are these folks benefited employees? In other words, do they get health insurance as well?
So they're hired through the temp agency. I don't know how many are Accenture-based employees and how many are temp agency-based employees. There's also a mix of part-time and full-time, because during the call center week, Mondays and Tuesdays are much busier than Fridays. So we've asked for more what we call front-loading, the part-time employees at the beginning of the week. Again, I can go back and find out benefited versus non-benefited. I don't know what the arrangements are between that staff and the temp agency.
Understood. No, that would be helpful. Thank you.
Yep. Okay. So in addition to the staff onboarding and training, like I said, we are looking at all of the processes in the background. So we have reviewed all of the training documentation that we have. We've added some new redetermination specific training for staff so that they're able to answer questions for folks who are a little bit confused about why this redetermination means more than, say, a redetermination from last year or the year before. We are working on escalation processes with MassHealth, and that includes us, if we get a call for a MassHealth member that needs to go to their call center, not just dumping them over into their 800 number. We will have specific phone numbers to get those individuals into the appropriate queues so that they don't have to navigate through the IVR on the MassHealth side. We're also looking at standard operating procedures for robocalls and text message campaigns. And obviously staffing levels are affected by those campaigns as well. So making sure the timing of those campaigns, we're not doing them, say, over the weekend or on a Friday when we already have larger volumes on Monday. We're being thoughtful about when those campaigns move out. We are reviewing and updating the workflows, the guided workflows for staff, and that's basically their knowledge center that they can pull up to help guide them through a phone call. And the focus on that is on eligibility, reporting a change, and any enrollment scenarios that are of a higher volume during that period. And then finally, we're working with MassHealth to provide support where needed. We've offered to help them with their robocall campaigns if they need help with any paper processing, the return mail process. So if we do have bandwidth on the connector side, we can help them on the MassHealth side. And I don't know if there are questions, but I'll turn the next slide over to Jason.
Great. Thanks, Trish. Hi, everyone. One of the new initiatives that we've created since we last met in February is a set of community specialist teams. This will create a new opportunity for people who need help with redetermination or enrollment. This project is being supported with funding from MassHealth, but we're kind of considering it a pilot with the prospect of continuing it ourselves after the first year. The plan is to create 4 regional teams, 2 people on each team, and then have 1 supervisor who oversees all 4 teams. Like I said, 4 regional teams, Western and Central Mass, the Boston area, north of Boston, south of Boston. These teams will go to public buildings like town halls or libraries, food pantries, homeless shelters, and other locations where there may be a gap in assister availability. We just want to make sure that people get the help they need, and there are some areas where an extra set of hands would be very useful. And we will, as we get the teams on board and figure out their schedules, we will promote their schedules locally, most likely through paid targeted social media, along with some other measures to ensure people are aware of when this assistance will be available. It doesn't do us any good to put people out somewhere and no one know that they're there. And the goal is to have these folks out in the field by July. Can we go to, thank you. Also, over the last month, we've been working with the administration to ensure that the Commonwealth's business community is aware of the redetermination process and that they understand that current employees may need to be added to employer-sponsored plans. We've created a package of materials, including a letter from state leaders, an FAQ, a template newsletter copy for business associations to consider using, and a flyer that's more employee-focused. And this would all go along with the new web page that'll be launched this month. The goal is to increase awareness and encourage businesses to check on employees and help them get coverage if they need it. We also really want to reinforce the really important 60-day window to get added to employer-sponsored coverage if you're moving off of MassHealth. We understand that some employers may think there's only a 30-day window. We want to make sure everyone understands it's 60 days. And thanks particularly to Eric Golko for highlighting this for us as we went through this material. So the material encourages employers to enroll newly qualified employees into their plan or direct them to the Health Connector if they don't offer a plan, or maybe if their plan is considered unaffordable. So this will all roll out really probably starting in the next week or two. We'll start meeting with the employer organizations and the business community and getting the word out. So next we're going to talk about our outreach and visibility plans. At our last meeting, we talked about direct communication plans to people who are transitioning out of coverage. Today, we're going to focus a little bit more on our public visibility and outreach, which we'll work on it really in tandem with those direct communications. I think as we said last month, we are preparing for our largest public outreach campaign in really almost a decade as we meet the moment with the prospect of somewhere between 100 and 200,000 people enrolling in Health Connector coverage. So today we'll be seeking a vote for a $3.6 million contract with ASG. I think many of you know it's been our longtime outreach and communications vendor, and they're going to partner with us on this project. ASG has been working on creative development and production with MassHealth and Healthcare for All in the first phase of the project. We did budget $500,000 for this fiscal year for that work and for this work going forward. So a little bit of that is included in this $3.6 million. We had also budgeted $1.5 million for communication and outreach in fiscal year 24. And thanks to recent approvals from the Executive Offices of Health and Human Services and Administration and Finance, we're including a $2 million investment from the Commonwealth Care Trust Fund in this work. Really a significant portion of this project is going to focus on public awareness so that people coming off of MassHealth at any time over the next year understand the Health Connector is available and the only place to get help paying for coverage. We want to make sure that everyone understands that we are the state's official marketplace. We provide access to essential benefits and services that meet state standards. And we really want to work to ensure that people shopping for coverage avoid scam plans. We know that's going to be out there. So we want to hammer away at coming to the Health Connector and nowhere else if you need health insurance. Thanks, Marissa. So a big part of this project is going to be paid media. This campaign is going to be powered by our biggest media campaign since New HICS was introduced in 2014. And back then we were requiring all members to create new applications for coverage. Folks remember that process. We're in a far better position today than we were then. And we're really looking forward to building awareness of the Health Connector as a place to access more affordable coverage. Historically, we found that when we've done television advertising, it's very effective in brand building and awareness. I think most recently we did the World Cup campaign back in November during open enrollment. Generates both applications and enrollment. So we'll be leveraging television again as a sizable part of this program. We've already started talking to Telemundo and Fox about packages for the Women's World Cup, which runs from late July through late August. We're also planning an ethnic media campaign that's at least as ambitious as our open enrollment efforts. And we'll also work on some space on the T, regional transportation, and billboards if a package there makes sense. On community activities, being visible and active in communities with high enrollment needs has been an important part of our outreach over the last 7 years. And we intend to use those existing relationships and expand on them as we go through the redetermination and enrollment process, along with distributing literature like signs and flyers and participating in local community activities. We do plan on hitting the road early and often, visiting navigators, participants in Healthcare for All's community-based organization program and other locations. A significant part of these community-based activities will focus on a series of 18 enrollment events that are going to be held around the state. These events will include navigators, CACs, and other community specialists who will meet directly with people who need redetermination or enrollment support, sort of one-stop shopping, if you will. Want people to come in, whatever questions they have, whatever needs they have, they walk out the door either in a plan or well down the path, or maybe they just need to make a payment or whatever to complete the process. And we'll also make sure that carriers, health connector carriers will be welcome to attend to provide information to people about their plan offerings. You know, if people are kind of sitting around waiting, it's an opportunity for them to do a little learning and research before they sit down with a navigator or a CAC. We're working on the schedule for these events with the first handful of events set up so assistants can begin working on their calendars. We should have the first 3 or 4 months of events scheduled by early April. But we do expect the first event to be held in June. You know, give a few months for the redetermination process to start for people and get that critical mass where if we're holding an event, there's enough people who are ready to go and come out and get help. But the plan is to hold the first event in June at Fenway Park in conjunction with El Mundo's annual health fair. We will be the presenting sponsor of that event this year. And then we'll follow up with events in Worcester and Springfield as we try to get a start in areas where we know there's going to be the largest number of people transitioning. So we ask for a vote, probably amending, taking acting out of the vote now after today's meeting.
Maybe I'll call for a motion to actually, actually, can we amend with the amendment to take on acting executive director? Just leave it as executive director. I don't know if you can amend it in real time, but.
As amended, so moved.
Second.
Okay, Kathy, I think we need a voice vote. And before a vote, Nancy, did you have a discussion?
Yeah, I just wanted to make a couple comments. First, I think this is exactly the right strategy of going very big on outreach and enrollment. This is, I think, the most significant outreach and enrollment effort really since 2006, 2007. So I really want to applaud the staff for pursuing that as a strategy. Also, the emphasis on community partners, which we know is really important. The one thing I want to say, I as someone who's been on the board, I think the longest, whenever we've had challenges in the past, like big, huge challenges, it's been in large part vendor failure. So I just, want to say that we obviously have to go with a vendor this time, and we're going to be extremely reliant on Accenture delivering. And I know that that's on the minds even more of leadership and staff, but our ability to really manage Accenture and have them deliver is going to be critical here. And then I hope at some point down the road, when the dust clears on this, we can take a step back and look at our overall reliance on vendors. It makes me nervous in some of these areas. And obviously you have peak times and extraordinary activities where you have to bring on more, but I would just like us as a board and leadership and staff to think about that. And then the last thing is, and Secretary Walsh, you alluded to this in your some comments earlier, this is really the first time when we're going to have to do massive redeterminations of people when the plan that they've been in at MassHealth is not the same. For many of them is the plan that they're going to be needing to join. And I'm sure we're paying particular attention to that, but this MassHealth ACOs versus our our plans is going to be very tricky for lots of people. So I just would emphasize, and I'm saying something that you all already know, really the need to pay particular attention to that in training people in our outreach and enrollment, because there's going to be a lot of dislocation here in a way that hasn't happened in the past.
Although I do take some comfort, and maybe it's the courage of the non-combatant, that people will be, the MCOs, the MassHealth plans, and the new premium plans, to the extent that they're the same carrier, they're going to be very highly incented to keep that member and highly incented to do the outreach. And we need to make sure that that's done in a way that's appropriate, that preserves the marketplace, the market imperative of the connector. Audrey's been helping me understand this a little bit even as I've started. So I think that, and the other, if there's good news, is and there's a question at the end of this, I think the redetermination rolling into open enrollment, I think we will catch people at a couple of different spots along the way. So I don't want to minimize this effort, nor do I want to be in front of a camera explaining that it was a vendor's fault. But so your points are really well taken, Nancy. But this is a very big thing, and I think we should all, reassure ourselves, but also, reach out to Audrey and the team and say, I thought of something else, or did you guys think of this, or have you talked to this person because they're worried? I have been torturing the MassHealth team nonstop since I got here, but it's only been 5 days, so they're still letting me do it because I keep thinking of something else that could go wrong with redetermination. It's a big, big deal for the Commonwealth. Yeah, and people come to rely on health insurance, as well they should. Yeah, but
I've always been comforted and inspired by your optimism, Secretary Walsh. So
well, it's early. Early days, but yeah.
Well, I've observed that over many decades. So.
Eric.
Yes, thank you. I was just noticing earlier in the presentation, I thought maybe it'd be a good time to bring it up since we're talking about education and transitioning people. As we're introducing people to carriers, and maybe they haven't worked with those carriers or been on those carrier plans recently, as we're expanding carriers on connector care, just want to make sure that we as an organization continue to educate people that the name of the carrier is not necessarily the network that they think it is. So as carriers are added to connector care, I saw Blue Cross, I saw United. What they'll try to do probably to meet the cost requirements, the premium requirements, are going to have narrower networks, which is absolutely appropriate and acceptable and a best practice. But we just need to make sure that the consumers understand that it may say Blue Cross on there, but it may not be the Blue Cross network that you were on when you're on a group plan. It might be a narrower one. And I think the connector has done an outstanding job in improving that communication over the years. I've noticed in the beginning, you couldn't tell that it wasn't really Tufts. It was a more narrow Tufts network. And over the years, you've gotten much better at really kind of highlighting this is a narrower network within Tufts. So I would just encourage us all to continue to pound that education. And when people look at these carrier names, they're going to presume something that they maybe shouldn't presume, because the network might be different.
That's a really important point, Eric. What I don't want to do is lose the quorum before the vote that Audrey needs. So I thought I had a motion and a second. Did I, Kathy?
Yes, you did.
Okay. Can I ask you to take a roll call vote?
You sure can. Rebecca?
Yes.
Michael?
Yes.
Eric?
Yes.
Martha?
Yes.
Dimitri?
Yes.
Secretary Walsh?
Yes.
Nancy?
Or Kate? Yeah. Okay.
Well, thank you.
Yes.
Yeah.
Matt?
Yes.
Rena?
Yes.
Thanks, everyone.
I think you missed Feline.
I am so sorry. Dwayne.
Yes.
Thank you. Sorry about that.
Okay, the motion carries. Thank you. So Audrey, I think I heard a couple of important discussions for upcoming meetings, and really appreciate the lively discussion we had in my first meeting. And I think if I can entertain a motion for adjournment, we'll actually leave on time, which would be miraculous. And with gratitude to everyone for helping me through the technical glitches at the outset. Can I have a motion and a second to adjourn?
So moved.
Yeah, everyone's happy to do that. Thank you. Quick. But Kathy, one more vote?
Okay. Rebecca,
Yes.
Michael,
Yes.
Michael? Okay.
I
Elaine,
was mutedly yesing.
Elaine,
Yes.
Eric,
Yes.
Martha,
Yes.
Dimitri,
Yes.
I can't, Secretary Walsh,
Yes.
Nancy,
Yes.
Matt,
Yes.
Rena.
Yes.
Thank you, everyone.
Thank you, everyone. It was great to see you. Congratulations again, Audrey. And we'll see you next time. And thanks again for my first at bat. I'm feeling very confident. Thank you all.
Thank
Have
you.
a wonderful
Thank
day.
you, Secretary.
Bye.
Thank you, Secretary
Everyone.
Walsh.